Okay, well, welcome everyone to the Health and Disability Advisory Committee meeting. Acknowledge Janine Rankin. Do we have apologies? I have an apology from Norman Gray and from Matiroa Ma. Could I have somebody to second? I'll move.
Happy to move, John.
Thank you, Vaughan. Seconder. Thank you, Muriel. Those in favour, just raise your hand.
Aye.
Okay, I'll take it the motion's passed. Okay, on to, I'm sorry, I've got way ahead of myself now. Ko tēnei te wiki o te reo Māori, ko te kaupapa tuatahi ko te karakia, o kei te ino e tātou. Let us pray. Kia hora tamarino, kia whakapaunamu, papatapaunamu te moana, hei huarahi mā tātou I te rangi, aroha atu, aroha mai, tātou ia tātou, ina wā katoa, hui e, mai ki e. Kia ora tātou. And Tracy, I think you win the prize for the best seasonal background.
Thank you.
Okay, look, I'm sorry, back to apologies. We've accepted apologies from Norman and Matiroa. The motion has been moved and passed. Do we have late items? No, okay. We'll go on to the Register of Interest. I'll take it that the Register of Interest is up to date, but does anyone have anything to add? Vaughan?
Yes, John. Last night I forwarded to Margaret and updated some interests that I have that need to be added to the register. So they'll show at the next board meeting.
Okay. Are there any items on today's agenda, part 1 or part 2, that may create a conflict? I'll take that as a no. Thank you, Vaughan.
Thank you.
Okay. Well, we'll move on to the minutes of the last meeting. We'll take them as read. Are there any omissions, additions, or corrections to be made? Okay. Vaughan?
I'm happy to move, Chair. Thank you.
Thank you, Vaughan. Do we have a seconder? Thank you. Thank you, Karen. Okay. Are those in favour, just raise your hand, please. Those against? Thank you. The motion is carried. Are there any matters arising from the previous minutes? No? Okay. Very quickly, we have an next paper, it's item 3 of the agenda, a presentation on the Regional Service Integration Update by Lynn and Jeff. Are we ready to go, Judith?
Yeah, I believe Lynn and Jeff are in the room and we'll be speaking to it. Yeah.
Okay, thank you.
Kia ora koutou. Lynn and I are socially distanced but in the same room, so we can answer any questions on this paper. Through you, Chair, a couple of highlights and a couple of updates from when the paper went in. The vision behind this is clear in terms of making certain that it's around what is good for the patient, not what's good for the funding or the boundaries that we have artificially put in place. It's also moving away from the model of a tertiary and secondary care to actually look at increasing any complexity or increasing rarity of care and a graded approach. It's also not to be to the benefit of one hospital or DHB over another, but the improved benefit for the entire population by looking at perhaps a cleverer way of putting care together. So getting rid of postcode lotteries, getting rid of complete dependence on single clinical staff, or having what can be done dependent on a piece of equipment or a piece of IT, so that clinicians can work across hospital sites. This is not just doctors, but nurses and allied health, that the patient gets the care where it's best not necessarily where it's closest, because the best care may be actually at a smaller, at some distance. But actually the idea of both clinicians travelling to the patients as well as the patients travelling to clinicians. In terms of the update, the urology draft white paper has been presented to both chief executives of Wairarapa DHB and MidCentral DHB and had their resounding endorsement to progress. The urology service is dependent on getting more urologists. It is dependent on joining up access to IT, and it's dependent on agreeing on the equipment and approach to such things, even such basic things as how to do a prostate biopsy. Believe me, that is not standard across the country, but once you get urologists agreeing on that and agreeing on the equipment they need and how they're going to do it, then you do get a reduction in variation or unnecessary variation. So that has had the go button pushed on it. The urology team here are working on how to make an attractive job description, which actually puts together working across more than one site, and also linking up with the work that's already been done to date with Whanganui DHB. The other specialties, we'll leave orthopaedics out of it at the moment because that's a moving feast, but the other specialties are outlined in the last slide 13 of where they're up to in terms of using the template developed for the draft white paper for urology and moulding that to the particular needs of the specialties ENT, gynae, ophthalmology, gastro and paediatrics. I'll leave it there and happy to take questions between Lynn and myself.
Thank you, Jeff. That was a most expeditious presentation. You skipped over quite a lot of detail there, but I think I was most interested in at the beginning, prior to your slides on urology, with the diagram on page 13 around the principles of service integration, which you spoke briefly about. Now, almost every speciality brings exceptional things to this. I think in terms of just urology, for example, you talked about just standardising the manner in which a biopsy is taken. How far away do you think we are from arriving at a standardised procedure for diagnosis here with under this proposal?
I think I'm not a urologist, so I'll be careful yes. Here. But I suppose I can declare I haven't had a prostate biopsy yet either. But what I am told is that if you have a team of urologists working as one service across multiple sites, the team determines what is the best approach to a variety of patient groups. If you have isolated single or two-person departments, things tend to drift apart, and you do what's expedient with the equipment you've got. But if you have a multi-site, and in this case it could be Whanganui, Palmerston North and Masterton, you end up using standard procedures, standard equipment for the majority of patients, more or less on an 80-20 rule. 80% will be done in a standard way, and then you get the 20% of more specialised approaches needed. That way you actually get standardised outcomes rather than the outcome being dependent on which hospital you happened to be living closest to.
Okay. And just my second question is, you skipped over orthopaedics. Is there anything we should be aware of in terms of coordinating orthopaedic services with Wairarapa?
I think I'll leave that to Lynn to answer.
So look, we have had a regional meeting. So as part of this, Capital Coast Hut and ourselves have been supporting the acute orthopaedic service at Wairarapa. We're all having our week on call and supporting at a distance with their general surgeons and emergency department physicians and patients travelling across when they require surgery. That will probably continue, John, until the end of the year. And the discussion at the moment is, what does a single system of orthopaedic care look like, and moving into next year in a networked hospital sense. And not one hospital has enough capacity to do all of the work, be that at Wairarapa or acutes moving. So we're actually all working together as one. The clinical leads are driving this, and it's very positive. And MidCentral, we will all have to be involved, because there's certain Rumataka Hills and weather and all sorts of things that happen. So look, it is very positive, and they have a proposed model, and it will be about delivering elective surgery at Wairarapa to the community there, or a level of it, and then what that single system looks like in regards acutes. And there will be a presence of orthopaedics at Wairarapa moving forward, whether that comes from the other hospitals in the region. Yeah, so it's a work in progress, but a positive work in progress, I think, particularly for orthopaedics, which is always can be a bit of a challenging service. Yeah.
Thank you, Lynn. To the rest of the committee, are there questions for Lynn and Jeff? Brendan. And
just the first observation is a compliment. This is almost happening at lightning speed for me, given my experience in health. So I do want to say, a very serious congratulations and compliments to everybody that's made the program get to this point. Kelvin, I remember that trip to the Wairarapa. I don't know, it was only 18 months ago, I think, not even that maybe. And the progress is fantastic. So really well done. It's heartening news.
Thank you, Brendan. Kenny and then Muriel.
Yes, Morena, can you hear me okay, John?
Yes, fine, thank you.
Kapai. Thank you for the presentation, Jeff and Lynn, and certainly regionally, it sounds like a great advancement. I guess for me in reading it, and you've spoken to, some of the success in it being in the ability to build the team. I guess my just concern or hesitation is around, when we think about the SMOs presenting to us and the real concern around the challenges, both workforce and theatre capacity, although I'm assuming it's mainly workforce in to serve our own community. I'm just struggling to understand how then we can serve wider communities.
Okay, through you, Chair, that is absolutely on the nail, and until we get a commitment to expand the consultant urologist workforce, this can't go ahead. So that is where the joint commitment from the chief executives to do that, and although Brendan said this has proceeded at pace, the thing that is the most rate limiting step is going to be recruitment of sufficient specialists, a minimum of 2, to actually make this go ahead. So that commitment to actually head off and get the recruitment going is going to be critical, and is critical to this success, because it isn't going to be about loading more work onto the already stretched workforce.
Thank you, Jeff. Muriel.
Thank you. Through you, Chair. I just want to reiterate what Brendan said about the pace that this work's been done at, and it's quite amazing when you can get a team together and actually achieve this sort of work. I also do just have a comment, maybe it's a question, just reflecting back on the challenges we had with earlier, several years ago, with working with Whanganui, particularly with regard to urology and maternity services, and just sort of wonder whether any of those sort of challenges are going to get in the way of this, or whether that has actually helped develop a much more robust proposed system going forward.
Thank you, Muriel. I think that it's quite clear that we have taken the learnings from what hasn't worked or the struggles, both in maternity or women's health and in urology. But we're also taking some of the successes, and the successes are when it is clinician-led and management supported. It is when you listen to what the clinicians need to make it work, and sometimes that's a different model in their heads. But also backing up with joining up access to IT and actually making some commitments to letting them try things that are different without quite knowing what the model will actually look like, but to develop it as you go. And that's allowed a delicate dance to have some outcomes which have not always been what you would predict at the start.
Okay, so that sounds good. Thank you very much for that response.
Thank you, Gail. And Gail, do you have a question? And then Catherine.
Yeah, kia ora. Through you, Mr. Chair. Jeff, I'm interested. I wanted to support Jenny's comments regarding the workforce, and can see in some of the other papers being discussed today that workforce is quite prominent too, as well as in terms of shortages. So that seems to be like a key thing, and I'm still interested to see how, in fact, you're going to mitigate that. And the second thing was, I wondered about the IT systems, whether they're up to working across the region, and I'm interested in your response to that. Thank you.
On the workforce issue, that is, and we identified the risks of the three major ones are workforce, IT integration, and the new health reforms. On the last one, we think that this is where the health reforms are heading, and so we believe that this is completely aligned with that. The workforce is critical, and it's not just consultant urologist, for example. For the gastro model, it's having some specific IBD nurses as anchor nurses that are working across sites is critical to that. So those are necessary steps before any integrated service can occur. And in terms of IT integration, it always seems simple if we've got similar systems, similar web PAS or similar clinical portal. The nuts and bolts of actually getting that are a little bit more complicated. However, workarounds are always there. For example, providing remote access to clinicians just by giving them permission allows them to get into alternative patient systems.
So currently the Wanganui MidCentral single urology service, they have a huddle every day by Zoom, and we do run one waiting list for surgery and for FSAs. Sometimes there are a few workarounds around the patient management system, but because they have huddles every day, they know exactly, and that works as a postcode blind service for next available appointment and next available surgical time based on the level of surgery you require, whether that's better at Palmerston North for equipment or at Wanganui.
Oh, hey, thank you. Just one follow-up question, if that's okay, John. I'm just interested to know, at what point then do you say we've got enough mitigation strategies in place, this is all good to go, we're going to launch it?
Simply when the clinicians feel that safe patient care can be provided. So really that's the call. And until the clinicians are happy with that, we cannot press go.
Thank you, Lynn. Thank you, Lynn and Jeff. Catherine, you had a question. Oh, you've got your hand raised.
Yeah, sort of comment really, a couple of points. So in urology, you'll see the next step is for the white paper, and then there'll be a regional model and an implementation plan. So to all intents and purposes, we're talking about sign off of a business case that needs to occur, which should have all of those medications quite clearly spelt out. And then the other thing to add to what Jeff was saying, which is kind of ironic given, I guess, where we've been of recent times, but this program of work has been supported by Francis Health, who were contracted in to support this by Wairarapa DHB on behalf of the two DHBs. using funding that was made available from the Ministry of Health through the sustainability funding that was made available to DHBs across New Zealand. And I don't say that to be niggly, I say it because I actually think having that additional support to help us, rather than people trying to do it off the side of their desks and already busy jobs, has undoubtedly been useful and helpful as we go forward.
Absolutely. Yep.
Thank you, Catherine. Gail, your hand is up. Did you have another question? Okay, thank you. Well, if there are no further questions, I'd like to note progress in the report for the regional services integration. Do I have a mover, please? Thank you, Karen. Seconder, thank you, Lou. Those in favour, raise your hand. Those against, raise your hand now. Thank you, the motion is passed. Well, we're running a little bit ahead of time. Are the cluster function, those people available for cluster function reporting in the waiting room?
I'll go and check.
We'll go and check, yeah.
Thank you, Lynn and Jeff.
Claire and Debbie. We're
Yes.
still waiting on Sarah, Saeed and Scott.
Okay. Well, shall we start with okay, we really haven't got anyone to start with at the moment.
Yeah, we're just about 10 minutes ahead.
Yeah,
So
yes,
I wonder whether just having a slight pause till we gather everyone might be the way forward.
Okay.
Are you
Everyone
okay with that, John?
Yes, I'm fine. Is everyone comfortable with that? Okay.
Yeah, whoever's managing the wait list, Jenny here, I'm just going to try and exit and re-enter and see if I can get the camera function working, which will make participation easier, I think. So just bear with me if that's okay while we have this pause.
Jenny, before you disconnect, could you just click your raise hand button just to make sure that works, just in case you come back and we still have no picture?
Yeah, I did that before and sounds
Okay.
fine, so I just want to try relaunching. Thank you.
We can imagine you, Jenny. Don't stress.
You got a photo on the desk there anyway, don't you, Brendan? So just look at that.
And just while we're pausing, could someone just tell me where you go to put your hand up on Zoom?
Are you on your iPad, Karen?
No, I'm on my desktop.
Oh, okay.
You go to the reactions down the bottom.
Is it up under chat? Oh, reactions. Oh, there.
Let's go to the kitchen sink and get one of those yellow dishwashing gloves.
Yep, got it.
That's a top tip, Brendan. I like that one.
Hello, Deborah.
Morning, everyone. Hi, John. Everyone's just joining now. We've just done a wee bit of a chase up.
Okay.
I think the only one we're waiting on now is Sarah.
Okay. Well, she's doing a bit of heavy lifting today. Actually, you all are. Look, while we're waiting for
Sarah's
Sarah,
joining now.
Okay. Look, before we start this session, I'd just like to acknowledge the staff in the executive leadership team for their wonderful work so far. You really are working above and beyond the call of duty, and it's wonderful to see this and to know that we're in good care. Okay. Well, if Jeff and Sarah are ready, we'll start with the first report on Turu Pāharekeke.
Hi, John. Would you like us to start with the overarching dashboard? Is that okay?
Oh, okay. Yes, please.
Huge apologies. So I'm hoping you can hear me okay. I'm just having a few problems with my Stella this morning, trying to see it. Hence, Jeff is with me with a report next to me. Probably there's a couple of areas that we just want to draw your attention to in the overarching directorate report. which relate to immunisation, and you will see in there that MidCentral was one of the 17 DHBs that received a letter from the Ministry of Health outlining concerns about childhood immunisation, and you will see in there about the planned response and the focus on specific areas in relation to that. You will also have seen that around the ash rates, that there's further information provided about that in more detail in the Te Ara Angito report that we're going to talk about later on. Also, the cervical screening rates, you will see that there's 3 key focus areas in there in terms of increasing cervical screening for Māori, Asian and Pacific Wahine to achieve and sustain equity and strengthening relationships, collaboration and integration of services across the pathway and sustaining cultural responsive services in there. We're happy to take any questions on any of that paper to start with. Thank you.
Okay, Karen.
Oh, thank you. Just my question was page 9 under workforce, the staff turnover rate seemed exceptionally low at 0.8 and 1.2%. I'm just trying to understand that. Is that just for the quarter? Is it a percentage for the quarter, or is it an annual percentage for that quarter? Just trying to understand, get that in context.
Thanks, Karen. My understanding it's for the reporting period, but I will confirm that and I'll come back to you later, Karen, to confirm that 100%.
Thanks.
Thank you.
Jenny, and there was somebody else had their hand up. It's disappeared. Jenny, sorry. Oh, Vaughan.
Kia ora. Morena koro, and Jeff, that's a stellar effort in jumping from one place. You're like a big Superman today. So change of outfit each time would be cool. Hey, just in regards to childhood immunisations, and we know on a positive, we know that iwi Māori providers are having a significant playing a significant contribution in our COVID vaccination rates. I know that these rates don't pertain to really current. However, we continue to just not quite get there, with those immunisation rates and for whānau Māori. Obviously clearly here, if we think that our iwi Māori providers are a key part to addressing, those inequities and trying to reach some of those whānau too. The report speaks of other mechanisms too, but I do just worry about the strain and resourcing of our iwi Māori providers that are playing such an important role in equally important vaccinations, but what your thoughts are and any reassurance you can give me around the realistic impact through no fault of their own that this may be having on our childhood immunisation rates.
Thank you, Jenny. I think Debbie's probably best placed to answer that question, if that's okay.
Sure, yes. Thank you for the question, Jenny, something that exercises us all. So currently we've been really clear with the upscaling of the COVID response, is we're working really hard not to be displacing key activities that we really need to keep our foot to the pedal on. And one of those is childhood immunisation. Though we did deploy some of our Māori nurse vaccinators in iwi, we're also rapidly working to increase our non-vaccinator Māori workforce at this point in time so that we can ensure that we've got sufficient capacity. I might as well talk about the plan that we've got with the ministry at the moment. One of the specific tactics was making sure that vaccination across the rohi was not displaced by COVID-19. So we've got a really close eye on where any of practice by practice for enrolment specifically, where any vaccination rates may be dropping, and seeking assurance from Think Our Water that all practices are continuing to provide the same resource alongside the iwi resource.
Thank you. Sorry, next is Lou.
Probably best to say it, but I just see there's a increase in admissions to the open ward. Is that just the winter increase, or is there something else?
So yeah, Said or Lynn?
I would attribute that to the increase in respiratory and cardiac admissions over the winter period.
Okay, that's what I'm wondering. Thank you.
Muriel.
Thank you, through you, Chair. Just a question about cervical screening on page 4. I was just wanting to know whether we've heard anything more yet about the primary HPV testing, because, you know, the theory behind that is that that would help our cervical screening rates. It can be self-administered, done in the primary sector and not invasive like a cervical smear. And we know that, you know, we've been waiting on further information from the ministry around where that's at. And I just wondered whether we had heard anything more. Thank you.
Thanks. Debbie, are you able to answer that?
I've got no further updates since we last briefed the board, Muriel. Kelvin may have more information, just checking in.
No, that's fine. Thank you.
Sorry.
Yeah. Thank you.
Sorry, Vaughan.
Thank you, Chair. Just really following up with Karen's query around the staff turnover rates, and if that feedback can come across to all of us, I was interested in that point as well. Not so much a question, just a follow up.
Yeah, of course, no worries. Should be able to come back to you within the hour on that.
Thank you.
Thank you, Sarah. Karen, you still have your hand up. Did you have another question?
No, sorry, I'm just a bit slow bringing it down. I'll do that now.
No, that's all right. I'm terrible at multitasking, so every one of you is much better than I am. I daren't put my hand up for that. Audiana's just going to disconnect. Her internet's playing up. She's going to try and reconnect again. Well, thank you, Sarah and Jeff. Turupa Harakeke, you're back again.
Thank you. Thank you, Chair. We'll take the paper as read. We just wanted to point out to you regarding the Tumiate Ururua project and the progress with that. We've obviously been delayed, as we reported to you previously, but we're now really pleased to report that we've got 220 consumer surveys and 25 provider surveys completed. An initial analysis of the data is indicating that we've got 29% feedback from whānau Māori, and we're actually having independent analysis of that data undertaken at the moment. Obviously that has been slightly delayed because of COVID level 4, because the person that's doing that for us was called into an IMT response elsewhere. But we are hoping to have a report to you, a detailed report at the next HDAC meeting. And also, just on the back of that, we've also got some sustainability funding for the first 1,000 days strategy, and we're going to use our learnings from the Tumiate Ururua project to progress that first 1,000 days. And we're doing that in partnership with Tracy and Paiora Paiaka Whaiora Hauora Māori. Thank you. Happy to take any questions.
Tēnā korua. Are there questions? E pātai? Yes, Brendan.
Can we just get a bit more of an update on the midwifery space where we are re-advertising, just in terms of a realistic timeline? It would seem to me that the likelihood of getting this position filled within the next, I would say, 6 months is pretty remote. But we've got a bit of a sense. I mean, what's your response to the timeline, and what's the level of impact that's having on the team as a consequence?
Thanks, Brendan, and I'm sure Selena may have something to say on this as well. Having Selena in the role that she's in actually has supported us significantly in this space. We're incredibly lucky to have an executive director of nursing and midwifery who's qualified in both, so that is fantastic. Obviously, it is having an impact. significantly on Selena and also on myself and Jeff in terms of the support we require, and also in terms of the workforce, making sure that we've got the right leadership for them in place. We are now progressing with the midwifery manager, previously known as the charge midwife, permanent recruitment. We were delaying that to enable the director of midwifery, new director of midwifery, to have some involvement in that. However, because of the delay in that process, we have decided to progress with that recruitment. And in fact, we're interviewing next week for those posts. I think realistically, we are probably looking at the beginning of next year before we get something into place. But we are incredibly fortunate as a DHB to have a Selena in the post that she's in.
Thank you.
Thank you. Vaughan.
Thank you, Chair. Just in regards to the COVID and the levels that we went in with child health, with the policy being only one parent can be with the sick child, I just wanted to understand, is that a national policy or is that a specific to MidCentral? And I wanted to understand the workings of it when mothers are in there for prolonged times looking after a sick child, how they manage their respite with the limitation of having a second parent relieve. Maybe I understand we're out of level 4 now, but we could head back up, as well. So I want to know how that works.
Through you, Chair, it is very distressing to staff to have such limitations on visiting, particularly for sick children. But we do follow at the alert levels the national advice, and as opposed to some, shall we say, other high-profile DHB north of us, the guidance is you can be tighter or more restrictive, but not looser than the national advice. So we have followed that. There's always compassionate grounds, and when we do have compassionate grounds for more than one parent, we manage the PPE and isolation, if you like, very strictly. But under level 3, it became much more relaxed in terms of parents swapping in and out. And under level 2, obviously we can have 2. But the criticality of trying to get limitation of the bubbles under level 4 trumps what would otherwise be the norm for care. But as I say, the compassionate grounds for seriously ill children or children being transferred to Starship always make exceptions, and we accommodate those safely.
Thank you, Chair.
Okay, thank you, Vaughan. Are there any further questions for Sarah and Jeff? Well, thank you, Sarah and Jeff. Again, just the observation that Sarah's doing a lot of heavy lifting this morning. So we'll go on to Dudu Mātai Mā. That's being a cancer screening.
I think Claire's going to present on this one.
Thank you, Morena.
Yeah, it's both of us, yeah.
Oh, good.
So Morena, everyone, you'll see the paper there, and I will take it as read. Just to provide an update, the replacement linear accelerator is now going through its commissioning, and we're hoping to have that treating patients by the end of this month or early next month. And also just to confirm that despite the COVID level 4 restrictions, all our patients continue to receive cancer treatment throughout that period. But we obviously put mitigations in place to keep both our staff and our patients safe. I'm so happy to take any questions.
Thank you, Claire. Vaughan, did you have a question for Claire and Sarah? Okay.
Sorry, I again didn't have my hand up. Thanks, Joe.
It's okay, my bad too. Well, if there are no questions, thank you, Claire and Sarah. Thank you. I will move on to Tudu Aroto with Lynn again.
Thank you, and thank you through you, Chair. And of course, a number of events have happened since the last HDAC with some NZNO industrial action and of course, COVID resurgence in our national alert levels. Some of that, particularly the July report, particularly around unplanned care and acute flow, that continues to be a strong focus for us across the organisation. We have outlined a number of streams of work that we are focusing on. alongside some of the medium term, which of course is our new EDOA and MAPU facility alongside our emergency department. And we continue to use our transitory care unit and flex that up for some additional surge capacity when required. June and July saw both months for our highest ever ED presentations into this organisation, and there were quite a large number of surgeries deferred in July due to those reasons for bed capacity. I've also given you the did not waits through that, and of course they have increased significantly through June and July, and that is of a direct consequence of the numbers waiting in the waiting room and the surge of patients that we tend to get. Good progress though, however, in SB2, and even with national lockdown, we did over 1,500 virtuals or telephone or Zoom consults. So we're still well on track to achieve our SB2 trajectories moving forward, which is positive. SB5 in July was quite static, and of course that has deteriorated given the national lockdown. So we did continue with our cancer, our non-deferrable work through the lockdown. However, some of our other workers increased that waiting list into SB5. So we have a plan with all our specialties, and particularly clinical review and clinical oversight. And as you can see, we put a bid in for more money with the ministry and received 369,000 to support the current programs of work we have going, but also to put in a registered nurse across the waiting list so that they can lead with the booking clerks to look at clinical risk and priority, and to talk directly to patients that require it and work with the clinical teams, and some administrative support as well, because this will be quite a focus moving forward. And we continue to use CREST. A couple of other things was that we did commence our first cardiac MRI, and we have purchased the software, and we have a cardiologist who is specialised in cardiac MRI, which means that our patients won't have to travel to the Hutt Hospital to have that done, moving forward. So that's quite a momentous occasion for the cardiology service as well, and stands us in good stead as we move forward, because cardiac MRI and CTCA are two of the diagnostics that we've progressed with to underpin the PCI service moving forward. Happy to take any questions.
Thank you, Lynn. Vaughan and Karen.
Yeah, thank you, Chair. My query was around the emergency department that did not wait, and understanding the increased lift, but there would be increased presentations too. But I'd like to see that in future as a percentage of presentations overall. But also the point and the concern around that for the patients that do not wait, there's a clinical if there's a clinical concern, a nurse from ED will follow up. And I'd like to know the percentage contacts around that. So, because if somebody leaves the emergency department and goes, what's the mechanism for us to monitor how much post-contact have we had via phone and re-followed up with an outcome for them to represent? That's a gap I see.
So in regards to some patients discuss that they're not going to wait, and they will have the discussion with the triage nurse, and will be given options, or they will be given advice and to come back, etc. So not everybody just directly leaves the department. For the ones that do actually, when their name is called, who have actually directly left the department, the nursing staff review that, and we have a number of clinical nurse specialists, nurse practitioners in the department, and they review anybody of risk, and they will follow up and make phone contact with the patient or contact the general practice as well. And we also monitor did not waits that represent to the emergency department within 24, 48 hours. Yeah.
Is there a way that we can present some of that follow-up stuff? For me as the governor, I just see that as exposure and risk, and an important part of the process, just equally as important as the showing us the numbers that did not wait. I'd like to know the follow-up actions and be assured that that's actually thorough and doesn't leave a sick or injured patient that hasn't waited left with a person discretion saying, oh, that wasn't urgent or was. I think that's...
So those patients are triaged, so it would be based on their triage category, their presenting condition, and that is a Australasian system of triage of those patients. So the nurses are very practiced in that, and we do audit our triage. So they will be very clear of the patients that they would see at risk and who needs to be contacted and followed up. And it's also done in discussion with the senior medical officers in the department. I'm not sure that I could capture that. It will be documented on their notes, that follow-up, and I'm not sure it's documented in the system. However, yeah, others may represent. Now, not necessarily represent with the same condition that they did not wait for 2 or 3 days earlier, but it is something we do look at. Yeah.
Okay. I'd leave it as a question mark for a gap for me. And thank you, Lynn. I know you can't take it any further than that at the minute. Thank you, Chair.
Thank you, Vaughan. But before we proceed with Karen, questions on Karen Oriana, Kelvin, you had your hand up. Did you want to make a comment?
Yeah, I was just in support of what Lynn was saying. I think it is very clear that the greatest risk for did not waits are the triage category 3s, and that is the highest group that are actually followed up on. The highest triage grouping that we have that did not wait are the triage category 5s, which traditionally are lower risk. So I am very confident that we are responding appropriately, and I don't think we should be following up with every single did not wait that comes into the department. I don't think that's a valid use of resources.
Thank you, Kelvin. Karen.
Yeah, thank you. Just want to support Vaughan's comments already on the did not waits, and that was certainly one of my questions too. In terms of the high number of presentations to ED and the high number of did not waits, yeah, it would be good to have at least some sort of breakdown of the status of those, as has been outlined. The July, I had already looked at it as a 13%, and I'm not actually sure 13% did not wait, so I'm not sure how that compares with earlier months. But my question around that really was, Lynn, you mentioned that that overflow into TCU is used to address that high attendance rate. Is the TCU being used 24/7 in that capacity, or how often, or what is the trigger to expand the space when the presentations are high?
So the TCU is actually used for patients who have been accepted as an admission, so they're for inpatients, so we can get them out of the department. We don't want them in corridor beds in the department. So that releases capacity for the ED to bring more people through from the waiting room into their cubicles. So it's around managing the risk in the waiting room through. So we can put up to 10 patients in our TCU, and the trigger is when our ED, it's in their red VRM response, and when they have more than, and I'm just going to probably, I think, more than 6 patients waiting for inpatient beds, and we will stand up. We usually forecast that forward. We usually have a good feel on the day of what's coming in, and we will staff the TCU accordingly if it's not required. If we can close it at midnight, or for those night staff, they will assist across the organisation elsewhere. But when we do stand it up, we do normally stand it up afternoon and overnight. Yeah. Okay.
And are there other overflow areas or strategies for the high number of presentations other than TCU?
So the TCU is for inpatient beds, and that is really the limit of our full bed capacity in the organisation. That is the only surge capacity we have. In regards to presentations through the RSV, the paediatrics and the emergency department worked well together, and we opened up, and later from 4 o'clock onwards, our orthopaedic outpatient, which is right alongside, and we stood up some paediatricians and nursing staff so we could take children out of the waiting room directly and see them there. So we have a number of flexible arrangements to try and relieve pressure to the best of our ability.
Okay, thank you. And just one further question, if that's all right, Mr. Chair. On page 6, under the major facilities projects, the second paragraph there, talking about the work to accommodate MAPU and EDOA continues and construction is scheduled to commence later this year. Now, is that the work that was originally called the pods, or is this something separate that's attached to Spire? I'm just trying to understand what it is that work is that's commencing later this year.
So that is the pods, but they need to be built on site. So we're sort of trying to go away from the word pods as in, you know, something that's delivered and put down, on the ground.
And in terms of when you're saying later this year, are we talking about October, November, or?
We are talking hopefully October, November. We look at this stage to open in April, Karen.
Okay. And in terms of mitigating managing the ED presentations while that construction is underway, what work has been done, and how will that look in terms of if ED is continuing to see high numbers? Will the construction be impact that in any way?
So the construction is a new build alongside ED, so it won't have any impact on the current emergency department at all. You know, at some stage we break through and there is a connecting areas, but that won't have any impact, no.
Okay. Oh, well, thank you for that. And I'm really heartened to see that progress is only hopefully within the next few months that we'll see that happen. So thanks for that.
Thank you.
Kia ora, Karen. No mai Oriana.
Oh, morena koutou. I just want to make a comment about ED, and I've been there 3 times in the last fortnight at different times of the day and in the middle of the night, and obviously been there for quite a few hours. I just want to make a comment that my personal experience is that there was one occasion where we had to have some follow-up, and I couldn't have asked for anything better, and this was outside of actually being an ED. The team that followed up the person that I was supporting, it was excellent. The other 2 occasions, and I don't, obviously nobody knows who I am or anything like that, and I do have a bit of a, an interest, but it seemed to me that on all the occasions that we were there, the place was brimming and that was, as I said, one was in the morning, one was in the afternoon, and the other one was, the middle of the night type activity. And the staff handled everything really, really well. The different people that were waiting in ED. The last time was yesterday, and there was, a couple of quite challenging people in the waiting room. And so my observation was that under the circumstances, ED functions really, really well. So I just want to pass that on as a, and I don't want to say a secret shopper, because that's not what it was. It was just as a family member supporting someone that needed to be an ED, and just observing what was going on, and the pressure obviously the staff are under, and just the way that they handle things. So there's obviously lots of good things going on in the background to ensure that staff are able to interact with families and whānau and patients that are coming in that front door. Yesterday, you would know that it was pouring, absolutely bucketing down outside. So that complicated things in terms of people being wet and uncomfortable. But it just seemed to me that the staff are managing all those things really, really well. So I just wanted to pass that on.
Thank you.
Kia ora, Oriana. There's, I think, a phrase that we can use, I think, quite generously for now, and that's grace under pressure. And I think that captures it nicely. Well, if there's no more questions for Lynn, we'll move on to the Kiriro and Debbie and Kelvin.
Sorry, John, we've missed a report.
Oh, we have? Oh, sorry. Tūri whakamau ora. I'm sorry. My apologies, Said and Lynn.
Thank you. Look, I'll just lead off with just a brief, and Said may want to add to that. I think we've provided some updates, including an update on the community capacity. We have also updated you on the COVID vaccination uptake in aged residential care by residents and staff. And unfortunately, I haven't been able to get a revised update for you today because we need to reach in to get that from them. And of course, we did a second residential aged care COVID-19 preparedness survey, which 100% of staff have attended education and training in all aspects of COVID-19 plan and PPE, which is good to see. So Zaid, have you got anything else you would like to add?
Morena. The only thing I want to do is point out the typo under section 2.2. I'm sure the committee will be relieved to know that the Riverstone facility has more than 5 beds. It's actually a 56-bedded facility.
Thank you, Said. I missed that. My bad. Any questions for Lynn and Said? Oh, 2. Heather, and then there's Heather, Gail, and Oriana. Heather, would you like to address us first?
Hi, folks, and I do apologise. I'm having to sign in on my phone, so I've been coming and going a bit, but I've been listening. So I just had a question about, the reporting, goes back to immigration issues again, and I was listening yesterday, I think it was, to a report on Radio New Zealand that a lot of aged residential care facilities are struggling to staff because of the reliance on people coming into the country and nursing support particularly. Is that a problem in our region?
Selena, sorry.
Currently, across the country, it is varying as to the percentage of internationally qualified nurses. In our area, in the Manawatu, it's about 30% of our nurses are internationally qualified that work in our aged residential care areas. And of course, it will impact. They are managing, but it is going to impact, yes.
Yeah, I just, through you, Chair, I just noted in that report, some aged residential care providers were reducing bed numbers in response to it because they didn't feel they could safely staff. So that could present us with some problems.
That hasn't occurred here yet, no, but something to be mindful of. I did listen to the same, the same on Radio New Zealand, Heather, yep.
Yeah, I'm not aware of any bed reductions either at this stage.
No. Okay, thank you very much.
Okay, Gail. I'm sorry, Gail, could you unmute your...
Oh God, yeah, I was searching for it. Sorry, John. Okay. One of the questions that I had was around the 2.2, the community and care in the community. And I was just interested about the care being offered to ACC consumers to support their rehab in the community. And I wondered if it's going to differ significantly from the support offered in the community to people who need that support, but they are there by way of illness rather than accident.
Yes, you're right, Gail. At the moment, the rehab in the home program is only available to those patients who have, and usually they've had a fracture, so they are ACC clients. But as you will be aware, we have been trying very hard to get approval for our Opal community service, which I believe will address the other group of patients that you referred to. And I think there is some good news that will be shared with the committee at some stage on that front.
Excellent, thanks, Syed. The other, John, I just had another couple of comments. One was about the associate charge nurse role in Staff 4, and I just wanted to say congratulations. I think that's a really good initiative. with respect to equity. And just the third comment was about the large waiting list for occupational therapy. It's quite significant, isn't it? And I just wondered what the long-term prospects are for recruiting in that area.
So Gab might be able to answer that. Yeah.
Yeah, morning everyone. Gail, yes, it is very difficult at the moment in occupational therapy. They're currently sitting at nearly 5 FTE vacancies. Despite that, they have reduced their waiting list by 30 people in the last month. We've got some mitigation strategies around looking at what the waiting list criteria is and how we can triage the waiting list slightly better. Although I think they've tried every opportunity up to date now. We've got a bit of a plan with some contracted resource to help within the rehab ward, which will take some pressure off. But it is a bit of a moving feast. And I noted that our recruitment and retention, we've been really low across the DHB, but it's not reflected particularly in that service. It's had a high vacancy rate for the last 12 months. Best opportunity to recruit is with the new graduates. And of course, if you get a new graduate workforce, you need some seniors to support them. So yeah, it's a bit of a challenging space for that service.
Yeah, sorry, John, if I could just make a final comment. I was just joining the dots between this work here and that into Ururohi with there was quite a bit of reliance, I thought, Scott, on the appointment of occupational therapists in the employment space. And I just wondered how it was going to be all managed, but that's another question for Scott. So thank you, Gabriel.
Kia ora, Gail. Vaughan.
Chair, 2 acknowledgements really in this directorate. One, I can just hear Matero, why her absence is here. I just want to acknowledge the equity appointment in the staff 4 and the leadership support that's been put in place around that to give that voice. But also under 2.1, the Ombudsman's report, the surprise visit, just reassuring knowing that they've found that we've covered all their recommendations and that was addressed, and happy with the progress there. So just 2 acknowledgements. Thank you, Chair.
Thank you, Syed. We saw your thumb. Okay, any further questions for Lynn and Syed? I'm sorry I skipped over you, but as there are no further questions, we'll move on to the next paper, Duru Kiriro, and Debbie and Kelvin.
Kia ora koutou. Thank you, John. We just want to circle and give you a brief update on our COVID response, because I'm assuming that's probably going to be quite timely. The outbreak nature in Delta provided us the need for a different response in the last few weeks. So as you have seen by the report, we surged rapidly with our testing, making sure people had access in all localities and extended hours, and we managed that really well. We surged at over 3,000 tests in a week, possibly not as high as we thought we might get, obviously related to the fact that we didn't get any community cases here. We're still testing at an elevated rate of about 1,200 a week, including the testing of people that are crossing the Auckland border, so that'll we can predict some of that work. We moved into contact tracing and investigation and activated a 7-day roster quite swiftly, and needed to activate an additional 15 staff out of our surge plan, including 12 from MidCentral and 3 from PNCC. So a big shout out to the services that helped us to surge rapidly. As you'll be aware, there's been a significant number of localities of interest in this outbreak. So the nature of the work was different for us. The contacts peaked at nearly 40,000 nationally. So locally, our team has continued to manage a cohort of these, and we're currently leading on the supermarkets of interest. So we look into any new supermarket of interest in terms of the likelihood of those contacts needing follow-up. As you'll see from the report, we had a newly appointed SIQ, so that's Supported Isolation and Quarantine Coordinator, and across lockdown she achieved some significant work working closely with both the IMT, the Public Health Unit, and iwi. We do have an interim plan in place and can accommodate up to 2 family bubbles locally now. Our primary care moved to the virtual and supported care overnight swiftly. Lots of practice last year, so a big shout out to the General Practice Network, with a particular focus on the supported care of those people in home that were more vulnerable. Vaccinations, as we know, were halted temporarily, and we had a new priority worker category that we needed to focus on as we stepped back into vaccination after 2 days, and that was the supermarket workers, dairy owners, taxi drivers, etc. We also put on an extra intervention to offer vaccination on site to our MidCentral staff and managed to complete a few more of those. We scaled the capacity swiftly and diversified our delivery, and as I've seen from the media, Kiwis really like their cars, so the increase in drive-in delivery of vaccination was popular, and I suspect will continue to be popular through the drive-throughs. We're continuing to keep a really strong focus on delivery. The message is to keep going. We scaled at over 18,000 in our peak week. Our original plan was to get to about a scale of 12. So I just want to acknowledge the significant effort of our 46 different providers across primary care, pharmacy, iwi, and our significant DHB workforce as we scaled, and we want to keep that scale up. I'll just hand over to Kelvin, who's just going to make a few observations around our progress.
Yeah, I think the current outbreak and some of the learnings from this, what has happened is that we are now doing some modelling and relying on some of the modelling that is happening across the country and just seeing how that would look with us. But I think one of the emphasis that is already coming through is that we need to be pushing for extremely high levels of vaccinations. And so there's been different conversations that have happened with Oriana, Tracy, just particularly putting emphasis towards or continued emphasis towards equity in the way that we're delivering towards equity. And so that will be continuing and accelerating. But I think the other key partnership into the immediate future will be with the PHO. And there's some work that myself and Paul Cooper with the district nursing team, vaccination leads are working on, and that's in particular managing clinical cases or large numbers of clinical cases in the community and the bridge between the community and the hospitals. So that's some work that is, I think this current outbreak has actually accentuated for us, and we're in the process, and we'll be giving some more detail first of all to the OLT and then further on.
Kia ora, Kelvin. We have questions from Lou and Karen. Lou?
Right, yeah, sorry. 2 questions. Do we have a percentage of vaccinated people in Palmerston North? And just as an interest, do we know what level of vaccination we have among our staff?
Yep, certainly coming through to the vaccination of staff, and this is some work that Kaya has been undertaking, but we're currently sitting at 84% plus, and I'm saying that based on survey results which are still being compiled and put together. It looks like the frontline clinical workers, that those figures are even higher than that and are sitting in the high 80s, low 90s, and that appears to be rather typical of healthcare workers, frontline health staff across the country. Sorry, Lou, what was the other question you were asking?
The level within Palmerston North, do we know how many people, what percentage of people have been vaccinated in Palmerston North?
Yeah, we're in the process of breaking down the figures across the district. So across the district, we're sitting at 34%, having had 2 doses. We've just passed the halfway mark as towards the over 300,000 doses that we're aiming for. But on more specific details and breakdown, more than happy to come back to you. Deb, do you know those figures off your head?
No, I don't.
I don't. Okay, so I'm happy to come back to you on that. There is further breakdown of our vaccination data that we are doing at a number of levels across the district. And again, that's so that we can target some of the interventions more effectively.
Okay, thank you.
Look, the only comment I'd make to that, Lou, is that our coverage rates in all the localities are pretty similar. So if we're sitting at 34%, then we can do the same on
I was really upset when I got to work last week and we started getting ready that I found over half of our staff won't get vaccinated. Just incredible.
Yeah.
Misinformation that's out there is just so much.
Yeah. And Lou, I think one of the things we can say is that certainly with the older cohort of vaccinated individuals over the age of 65, we've actually, or certainly 75, 85, we've got a very good uptake, and we need, but we need to keep pushing across the board and keep getting individuals into being vaccinated.
Yes, the younger ones that are not interested.
Thank you, Lou. Karen and then Oriana.
Oh yeah, thanks, John. Look, I just wanted to say well done on a huge effort around the immunisation. I've heard a lot of really positive feedback, and I think it's a huge effort to be delivering 18,000 immunisations in a week, and to get to where we've got to is a really significant milestone, I think. I had some communication with Kath yesterday, and I was trying to, I had some questions from someone about how we were tracking as a DHB, and there's a few really good graphics out there. There's one that New Zealand Herald's putting out on a national scale of what the percentage of one dose, what the percentage of 2 dose, and the percentage of the eligible population that still need to be vaccinated. And I wonder if that would be a really useful tool for us to track progress in our region, particularly motivating people as we get towards the higher percentages in the coming weeks and months, because that's going to be when it gets tricky to sort of get those people who are lagging. I'm not sure what the strategy is. I'm sure, Debbie, you and others have been thinking about this, but just sort of wanted to put that suggestion out there. I found it quite difficult to locate where we were up to. The link that Keith sent me was a really good one, and it showed each DHB where they were at in comparison to the national average, but that was still the 25th of August, so it's still a few weeks old. Is there any, what's the plan in terms of, and I guess it got me thinking about how we're putting that out there publicly, sharing it on Facebook, you know, what we're doing to sort of really rally the community to get on board to get those percentages well up, because I think that's going to be quite a big challenge in the coming months. You know, what's the thinking or what's the strategy for us to be sort of really driving that?
Shall I jump in there? See who's going to jump in first. Thank you, Karen. Thank you for the observations. We have done certainly some social media pushing around progress, and we have just strengthened our relationship with both Inkoa and Te Tihi in terms of the information that goes out. Certainly nationally, the feedback we're getting is that most of the hesitancy is actually about the safety profile of the vaccine, and we are moving into what we would call the amplification phase now, where we really want to be thinking about who can influence locally to encourage and support the decision to get vaccinated. But we certainly take your feedback on board about the visuals that we could push out quite easily. We did do that last year in the testing space, and the COVID case numbers each week. So.
Thank you, Deborah. Okay, we'll move on to audio.
Thanks, Debbie. That's great.
Tēnā kōrua, Debbie, called Calvin. Thank you for that. I just wanted to add to the conversation around vaccinations, and I want to mihi to Fielding Healthcare and Think Water in terms of the activity that happened at Manfield, or is happening still at Manfield. And it's my belief that that was the first drive-through in the country. I stand to be corrected, but we certainly have had the ability to trial different ways of doing things, and so we now know, you know, in terms of our Māori responsiveness, what may work better than the other things. And so, Calvin, thank you for mentioning that. Looking forward to working together with all those groups that have been mentioned. In terms of lifting the Māori response, everyone knows that in that 12 to 29 or 30-year-old age group, we are overrepresented. And we also know that that's going to be, some of those age cohorts in there are going to be quite difficult to engage in terms of their understanding of the vaccine. And thank you, Kelvin. Kelvin has very kindly offered to be on call 24/7 to talk to anyone, any group. I'm not 24/7, but I just, yeah, in terms of engaging and in terms of adding to our initiatives to boost that Māori responsiveness. And it'd be fair to say that we're quite worried about the fact that we are not where we should be. And so in terms of the think cohort of support too, being able to just be agile and take the learnings and adapt as we go along. So looking forward to our next phase in that space. Kia ora.
Along that, Calvin spoke to Grey Power and he did a brilliant job. And I think everybody there was vaccinated afterwards. So I can recommend him to anybody.
Kia ora, Lou. Well, thank you, Kelvin, and thank you, Debbie, and thank you for your questions. Look, really, we only have one strategy in the moment, and that's a preventive one around the rollout of the vaccine, and that is giving us time to prepare for what will be the onslaught of Delta. It's not a matter of if but when. So my congratulations to the public health team. Kia ora. Okay, we'll move on to our next item, which is Te Rohi. Scott.
Morena, everyone. So I'll take the report as read, just point to a couple of areas. So we have continued to be quite busy across services. The ward occupancy, although year to date is high, there's been some quite significant work over the past several months around a number of long stay patients. And so our ward occupancy has come down. We're also working proactively with staff and the unions around a range of actions to support the ward. Really, the other probably matter is really around the integrated model of care, and that momentum is really starting to push forward around the substantial change program. And there's quite substantial work happening in that space across a whole range of dimensions, as you can see, not only around workforce, but facilities, digital, and the like. So happy to take any questions. Thank you.
Kia ora, Scott. Okay, no hands have come up and I can't see any frantic waving, so I think there are no questions. But before we close this, I'd just like to put the following resolution that the committee notes.
Gail's got a question, I think, John.
Oh, sorry, Gail.
Yep.
My apologies.
Thanks, Scott, and thanks, John. It was pretty late. I was just looking through my notes and just thought, Scott, I'm interested to know what's happened to the paid consumer roles in the integrated service model?
So the paid consumer roles that are part of the integrated model are still continuing, but in a different form. So we've focused and had a consumer advisory group that's been running for a number of months, and we're continuing to utilise that group as a key forum. So rather than just having one or two people as consumer advisors, we've tapped into that group. So for example, and they've got a range of skills, experiences. So we're utilising that group and then particular individuals within that group to support pieces of work such as the ward inpatient design. So rather than having discrete individuals, we're utilising a much broader range of people with that experience and insight.
Cool.
Thank
Thank
you, Scott.
you. And my second question was about, I remember when the presentation was made to the Consumer Council, one of the things that Wayne Bissett said was that probably the biggest risk to the implementation of this was going to be inability to recruit the appropriate staff. Is that still something that you see as an issue?
I think, Gail, it's an issue specifically in the context of Māori nurses, and then specifically Māori nurses with mental health and addictions background. It's a very small pool already, and it is certainly going to be a challenge. We're hoping that what we present and the direction that we're heading around the new model will attract, workforce to want to come and work here. But it is an ongoing issue for us, yes.
Okay, thank you. Thanks, Scott.
Brendan.
Sorry, I knew I had a note. I just had to find it. On page 4, 1.5 inpatient facility rebuild, the very, very last line, and construction is still anticipated to start in Q3. I just wouldn't mind if you put the year just to tie us down. Q3 of what year?
I'm just going to have to think now. Is it, Kath, you help me out? I think it's 2023.
No,
to oh, no, 2022.
Yeah, next year. So the third quarter, it's a financial year. So the third quarter is the 1st of January to the 31st of March.
Yeah.
That's why I'd like the year in 2022.
Well, we need to put the financial year in because sometimes people use calendar years and that makes it even more confusing. So if we put 21-22, Q3, 21-22, yeah.
Well, thank you all. If there are no further questions for Scott, I'll close the session by putting the following.
Sorry, John. Q3 of the financial year that's not correct, is it? That means we're going to start. What's the Q3 of 2021, 2022?
The 1st of January to the 31st of March.
Is that what we? Okay. So in about 20 weeks, we're starting the build.
Well, the build will start with demolition works and groundworks.
I don't think we'll be starting to build in the third quarter of this financial year.
Well, how we're defining it is the commencement of the project of works, which will commence with the demolition of the buildings that need to go to make way for the program of work. But I suggest what we do is rather than worry about it in this meeting, we make it really clear in the report that comes through to the board on major projects.
Okay. For want of missing another question, am I safe to proceed in closing the session? Okay, right, Nicole. I'll put forward the following resolution that the committee note the areas highlighted in the dashboard in associated commentary. The mover. Thank you, Karen. Seconder, thank you, Brendan. Those in favour, raise your hand. Those against? I declare the motion carried. But just to note, before we go for our quick break, and we're running a bit behind time, there are a few highlights, and particularly of note was the commissioning of the Line and anticipated treatment starting next month. Congratulations, Claire. Okay, we'll have a break now. We're running about 10 minutes late, so could we restart at 25 to 11, please? Have a comfort break and a drink. Okay, the floor is yours, Michelle.
So I guess everything's in the report and I'll take that as read. Overall, Enable continues to perform at the required standard, and we're really, well, I'm really comfortable that everything is on track and there are no particular issues that I'd like to bring to the committee's attention. Other than some really positive news stories from customers, and that our volumes continue to increase each month. Are there any particular questions for me?
Okay, questions for Michelle? I can't see any hands coming up. And more people are joining, but look, just 2 comments really. The ACC contract, good positive news there, and the Easy Living van service, and just making, enable New Zealand more accessible. So it's those are 2 points I took from your report. Do others have any observations or questions for Michelle? Oh, sorry, Heather, and then Muriel.
Thank you, Michelle, and congratulations on all those things. And you already know about my excitement about MRES, but when will you, so you're expecting absolute confirmation when?
The process for that is a little unusual in that ACC aren't quite ready. So I understand this week I'll have a letter of intent confirming that we are the preferred supplier. We are unlikely to sign the contract for quite some time, but as soon as the contract is signed, they'll make announcements on GETS and we'll be able to formally let people know.
Okay. Thank you. Well done.
You're welcome.
Yeah, good to hear that. Muriel.
Thank you, John. Thank you, Michelle, for your report. I really just wanted to reiterate what Heather said. Congratulations on the contracts, and I know that it's not just a simple, straightforward thing. It takes a lot of work and diligence around that. So well done and thank you. And my other comment really is on the positive feedback. It's really nice to see some individual consumer feedback. We don't often get to see that individual, and it just gives you a little bit of insight into how people perceive the service and how they experience it. So thank you very much for that. Well done. No question.
Thank you both. I did contemplate whether I should put that customer feedback in there because we do receive quite a lot. The service to support people to apply for lotteries grants is completely unfunded, and we do it really out of the goodwill of the staff that are involved in their time, I guess. And we have really good results from that. In fact, I think we need to clone the lady in our team that does it for customers because she's not had a decline yet. And she does around 4 or 5 scooters a month for people. So it's a really good local service that we're able to offer. And then, of course, we sell the scooter from our store, which assists. So when it's appropriate. But other than that, I'm assuming we're good.
Thank you very much, Michelle. No questions, just plaudits. Well, I'd like to endorse the Enable New Zealand report to the 31st of July. Do I have a mover, please? Thank you, Muriel, a seconder. Thank you, Lou. Those in favour, raise your hand. Those against? The motion is carried. Paiaki Whai Ora report. Tracy.
Morena tātou I tēnei ata, tātou te wiki o te reo, nō reira tēnā kouta katoa. It's te wiki o te reo, so I hope everyone's giving it a go with their the reo lessons that they've been having over the past year. Nice to see you all. So I'm presenting my report and hoping it's been read this morning. I just want to highlight a couple of things. We've got Marcy Williams, who's just come onto the team for Pai Ora, and she's for the last 5 weeks been reviewing and refreshing the current Māori workforce plan Kaimahi Ora whānau order. That will be going to OLT and then to Mana Whenua Hau order for feedback, and then we're hoping to be able to finalise that and get on with the actions. At least Kaya is champing at the bit to crack on in that space. Moving to the combined board-to-board piece that I have in my report, just wanted to highlight a really neat conversation starting up with OLT about how we consolidate more the way in which we report on equity. And it may be that what we do is we consolidate. You'll note that the EOAs that are in the annual plan are now being reported quite well across the directorates. And then components which I'm leading out are getting reported into mine. So what we're hoping to do is consolidate up all that reporting under the non-financial reporting indicators, so that hopefully that'll get centralised a little bit better for you and it won't be so confusing. Although you do have a report today from the equity dashboard from our team, and that's child and youth. What I've done is place the internal audit that was done by TAS on equity in this report, because I wanted you to see just how things are tracking along. Just a reminder of those recommendations, who's leading out on the work and how we're framing this up. We're being supported by Judith here because we know that this is actually a FRAC report, but I just wanted to highlight for you that this work is taking place, that there's really key leadership going on across these issues that have been identified, because I know it's a bit of a passion of this board to make sure that we do get some traction in the space of Māori health improvement. And I just wanted to Skype really about Bonnie Matihaere and the award that she got down at Parliament Building in August, to just highlight to the board that she's received that award. Some really stunning work going on in Māori health, as Debs and Calvin have been saying in relation to COVID. We know that we've still got work to do, but we also know from a Māori health perspective that the program started where there are less Māori by cohorts. So the big work for us now is where mainly Māori are, which is in the younger cohorts. But yeah, just reiterating the great work that's going on with iwi Māori providers, our local team, our team of one, and just the stunning pieces of work that has been happening, and also for the PHO chick. So I'll take any questions against my report. Thank you.
Heather, kia ora Tracy, and then Jenny. Yeah.
Sorry, I didn't put my hand down before, but congratulations. Thank you, John, sorry. But congratulations anyway, Tracy, and thank you for your very thorough report. It was good to read, so thank you.
Thanks,
I'll put my hand down now.
Okay, Jenny, then Muriel.
Kia ora. Tracy, mine was just also to acknowledge Bonnie, and I was really delighted to see that you included that in your report. It's really important to celebrate success like that, and I have to say, as a Horowhenua local and whānau I'm married into, being the same hapu as Bonnie, I tell you what, if there was a face that for me in this area I put to being the face of COVID-19, it's Bonnie Matihaere.
Yeah.
And the over that lockdown period, my observation is she must have worked relentlessly, and she just constantly appeared in our whānau forums as a champion for Māori, for MidCentral, and for vaccinating and protecting our community. So I do want to acknowledge that too.
Thank you, Jenny. I'll tell her to watch this recording.
Yeah.
Muriel.
Thank you, through you, Chair. Kia ora, Tracy. Thank you very much for the report. I just want to reiterate what Heather said. Absolutely stunned every time I read these reports about how much work is being done and what is being achieved.
It looks like Muriel's connection's interrupted. We'll bring Muriel back when she's available. Oriana and then Gail.
Kia ora anō. It might be those of us that are living in the Manawatu district, we all seem to be having a bit of trouble with our internet connection today. It might have been last night's rain, but I just want to say, Tracy, I wonder whether you could expand a little bit on the COVID vaccination mahi that went on in the Foxton Shannon area, in terms of our smaller communities activating themselves and making things happen in that space. I'm not sure whether everyone on the in this meeting would know about that work.
Sorry, what specifically would you like to know, Oriana?
It's the response from those small communities to getting themselves activated in terms of a Māori response to vaccinating their community.
Well, what I can say is, as much as we can with our communities, we're trying to get them to lead out in support with closest iwi Māori providers or the pai order team, whichever works best. So we're just going into a space of planning now, particularly for those really bespoke opportunities to be working alongside of communities that we do need to be getting into. Calvin's doing some really deep diving into the data at present to have a look at the data by localities and thinking about how do we actually provide opportunities and initiatives that are going to work for those communities, right down to using our mobile vans. So yeah, lots of work going on in that space, and yeah, we'll be pulling you into that, Oriana. In fact, that plan that's being drafted right now is going to Mana Whenua next Monday.
Yeah, so the reason I'm talking about Foxton and Shannon is because, quite often we overlook, not intentionally, our smaller communities. And what we found works in terms of Māori responsiveness is exactly what Tracy said, is our own communities taking ownership of activities such as the COVID vaccination. But, without the support of the DHB and Think Hauora and responding to that call, I'm just really, really proud of our Foxton community and our Shannon community and responding the way that they did. They are only small communities. Quite often they miss out on lots and lots of things. And so I just want to acknowledge our whānau and our hapori there.
Thank you, Oriana.
Gail.
Thanks, John. Kia ora, Tracy. I really appreciated reading this report of yours, and I really liked the inclusion of the internal audit. I found it really helpful to see how you're operating and what your targets are. I thought that was really, really useful. I was looking at looking for the mention of the Consumer Council as well, and I saw in there the intention that more Māori should be recruited to the Consumer Council, and I don't think that there would be any opposition to doing that. I think that would be certainly part of our intention as well. I wondered, I've mentioned to you briefly about how consumer councils will fit with the health reforms, and also with the Māori Health Authority. So I'm just wondering, I don't want to put you on the spot, and we can always talk about this later as well, but I'm wondering about how you see Māori representation going on in that space, in the Consumer Council space.
Well, the interesting thing is we don't have a structure confirmed yet, do we? So it's really trying to figure out what that looks like, and then how that's from a Māori and iwi perspective, how that then is established to support the different levels, both at a local and in a regional level. I understand from the what's being provided by way of information through the transition unit that there will be consumer councils at the national level, but probably not something that we should be so much interested in. And so from my perspective, I think we definitely need to have that consumer voice flowing. We've been talking behind the scenes as an incident management team through the lockdown period of how we get the advice of community on our testing and COVID vaccines backdoor through Facebook. So that's been established, and also we've been doing that at a staff level, because the more we can get that customer consumer voice flowing, I think the better we're going to be able to respond to our whānau. And we're at that point now in the COVID program where we actually need to hear what are the explicit issues going on as to why people are either sitting on the fence or saying no about their vaccine. So it's really important for me to have that voice, but I couldn't be explicit to say right now, Gail, where those consumer voices need to be positioned, because I don't have the structure going forward.
Thanks, Tracy. I mean, what you're describing as well is a high degree of agility that perhaps the Consumer Council doesn't have as well. So there's a whole lot of things that come to bear on what the future might look like as well. But thanks very much.
Thank you.
Kia ora, look, Muriel's still unable to join us as far as I can tell. Look, well,
John, Muriel is there.
Oh, she is. I can't see
but
her.
she's just muted.
Oh, okay, Muriel.
I'm here.
We lost you, Muriel, so we're not sure what question you had.
Thank you, John. Sorry about that. I wondered what had happened. I didn't realise I'd cut out. My question was more about how can all of these things that Tracy and everybody across the organisation is working on, how can they be sort of brought together to make all that reporting easier? And I think you did answer some of that when you talked about reporting, Tracy, but, you know, as an example, we've got the shared work plan, we've got the Kamahi Ora, Whana Ora, we've got the TAS audit, and then there's probably 10 other things as well. And just wondering how you actually keep track of all of that from a practical point of view.
Well, actually, it's not that difficult for us as executives, and I guess it's because we eat, breathe, and sleep it. So, but the key thing is that we make it clearer for yourselves and for other audiences. So, as I said, well, I think when you cut out, Muriel, what I said to the group was that we're going as a way in our OLT to think more specifically about how we centralise our reporting on equity. And we may come back to you with a proposal that differs from what we currently have, which is the Te Ara Angitu reporting, the equity of action reporting inside of these reports to HAC and so forth. But we haven't done thinking around that yet. Sorry, Muriel.
Yeah, okay. Thank you. Yeah, thank you very much. That's great. And sorry, I disappeared. I don't know what that was about.
That's fine.
Right, kia ora. Anyway, look, if there are no further questions for Tracy, we'll note the progress updated for Pai Ora Pāki Whai Ora, the Māori Health Director. Do I have a mover, please? Thank you, Karen. A seconder? Thank you, Lou. Those in favour, raise your hand. Those against? The motion is carried. Thank you. On to our discussion papers, and Claire, it's good to see you here again. Now, before you start, Claire, Heather has indicated she has a potential conflict of interest. Heather, does that limit your participation in this?
I'm not sure it's a conflict. I'm on the SKINS group that for the one of the statutory bodies of the Ministry of Health. So I just have an interest. I don't believe it puts me in conflict, but I will stand out of the conversation. I'm very interested in this though. Yeah, if that's all right with everybody? I mean, the SKINS group is overseeing the coordination and registration of the attending practitioners for the end of life people making a choice. So I don't think there's a conflict there.
Perhaps you have a special interest in this area.
Yeah.
Okay. Well, I think we should proceed. Thank you, Claire. We'll take your paper as read.
Okay, thank you. So really this is for the information of the board. As you're aware, the End of Life Choice Act comes into force on the 7th of November. And as a DHB, we have obligations under the Act. As the DHB in particular, our obligation is around how assisted dying services might take place in hospital. It is anticipated most assisted dying will in fact take place in the community. But there may be situations where either a patient is in hospital at the time that the end of life assisted dying process was due to take place, or a patient makes informed choice they would like to have assisted dying delivered in hospital, either due to their own choice or due to the fact the facility they're living in is a conscientious objector to assisted dying. So as a consequence, we have developed a working group. This working group, although it is predominantly around the hospital administration of assisted dying services, it does have representation from the community. We have PHO representation. We have Anna Blackwell, who is both an ARC representative, but also is again on the National Advisory Group, as well as Jill Job, who's again an Asia Residential Care representative. And we also have Paora input, and we're very keen to ensure we have a Māori lens on our local DHB policy as it's developed, and also supportive care and spiritual care, with Sandy Ramage being on the group. And we're very pleased to also have consumer representation. So this paper, as I say, is for the board's information, but equally I'm happy to take any questions.
Kia ora, Claire. Do we have questions for Claire? Muriel.
Thank you, John. Thank you very much, Claire. This is useful to have this overview. Mine is probably, there's an obvious answer to this, but I wasn't quite sure. On page 3, the sentence says, any medical or nurse practitioner who is suitably qualified and willing, etc. Is there any particular thing that those clinicians need to have, or is it just about making sure they are registered and have had some experience in that area? Is there a
So at this point in time, assisted dying can be delivered by a medical practitioner or a nursing practitioner under the supervision of a medical practitioner. And the Ministry of Health are keen that any medical practitioner or nursing practitioner who provides assisted dying has gone through the training process. Now, the training is being provided in Wellington. Well, it was due to be provided in person at Wellington at the end of this month. That was a 2-day training program. The first day has now been converted to an online training, and the practical delivery, which was on the second day, is not yet finalised as to how that will be now done because of the alert level changes. But yes, the anticipation would be that these medical practitioners would have gone through some training.
Okay, thank you very much for that answer.
Thank you, Muriel. Any other questions for? No. Okay. Well, we'll note the current information available regarding the implementation of the End of Life Choice Act 2019, and note the establishment of the MidCentral District Health Board Working Group to ensure that MidCentral Health District Board meets its obligations under the Act. Do I have a mover, please? Thank you, Muriel. A seconder? Thank you, Heather. Those in favour, raise your hand. Those against? The motion's carried. Thank you. And we'll move on to the Quality and Safety Dashboard. Judith.
Mari, kia ora koutou. Welcome everyone. This is your report on the quality and safety across the organisation, and we produce this on a quarterly basis. So just wanted to highlight a few issues and take the paper otherwise as read. So overall, our performance is fairly stable, and as has been in keeping in previous reports against this dashboard, overall our performance is relatively strong. I do want to point out, however, that quarter to quarter, when we're comparing quarter to quarters, where there are adjustments or small changes within the numbers, the percentage increase can look quite significant. But if we compare that variation with the trend graphs within the appendix, you'll see that it's largely normal variation, and we will be drawing out any particular concerns or spikes in rates within our narrative. So I just want to give the committee that reassurance. Coming on to those areas where there may be some areas where we've noted some variation. One is the recent increase in falls with harm within the ward environment. There is some special cause variation that we've observed at the end of May and into June, which we are investigating further. But overall, our performance in falls with harm, I have to say, in the organisation is usually exceptional. We're one of the highest performing DHBs in terms of falls with harm. So we are looking into each of those individual events and reviewing them significantly. We've also seen in Q4 increase in serious adverse events compared to previous quarters. However, when we've looked more recently at the HQSC's national data, which has only just been published in the last couple of weeks since this report was finalised, there isn't any significant we're not an outlier in any significant way in regards to adverse event reporting, and we are investigating, as we normally do, each and every one of those adverse events in some detail. You'll have also noticed the increase in the last quarter in Maori adverse events, or adverse events impacting Maori. And we are working with Paiora to ensure that each of those events are thoroughly investigated and taking a whānau lens to each and every one of those. And finally, I wanted to draw the committee's attention to the new inpatient experience survey results, which we brought to your attention for the first time. You will remember that the HQSC have changed the provider, and we haven't been able to provide that report for the last year while that new data is being analysed. So in our appendix, we're now able to provide you with that data, and it does show where the DHB is doing particularly well and also some areas for improvement. But I would like to highlight that the information here doesn't differ significantly from the previous survey results, in that the areas we want to make improvements in are largely around how we support people with their discharge planning and their transition out of the hospital into the community, and giving them a sense of empowerment and confidence in managing their own health in the community. Where we seem to excel is in our care in the ward environment, which I have to say the results are very, very positive around. So I'll leave it there and see if there's any other questions that anyone would like to ask about this report.
Kia ora, Judith. Jenny.
Kia ora, Judith. Thank you for your report and dialogue. Can you just help me understand, because I obviously am just reading it a little bit different, and I'd be interested in if my board colleagues have too, because the way I read it is that if we look at the indicators, we have you know, increased red being a negative change. There's a lot of red up arrows being an increase of greater than 5%. So we have a decent proportion, and just pretty much everything except patient falls, that we've got a negative increase of greater than 5%. Yet so that, I have to say, to be honest, as a governor, that concerned me. We also know that our staff in hospital are under considerable pressure. So when I look at that, there's part of me that can't help but think, is this the result? Is this what this is resulting in? But then your narrative at the start of what you were, your presentation was about that this is static. It's not, you know, different than last time. So I'm a little bit confused about how I'm reading it as a greater than 5% negative increase, and you know, pretty you know, negative consequence events. And then the other thing, while I'll just finish my question and then for you for response, is can you just help me understand again in terms of SAC? So that is quite different, the number, than what we see, you know, at a board meeting and just those, you know, SAC events. But are they only SAC 1 that we are seeing as, you know, in part 2 of the board papers, whereas this is SAC 1 and 2? So the majority of this is SAC 2 then, am I correct in that assumption? Thank you.
Yeah, I'll answer that one first because it's the easiest one to answer. So you're correct. The report in part 2 is just the SAC 1s, and we've agreed that we would report those in some detail in the part 2, which is just the SAC 1 reports. The vast majority of SAC events, or SAC 1 and 2 events, which are the reportable events to the Commission, are SAC 2 events. So you see some trend analysis here, but you don't see the individual detailed analysis of each individual incident in the part 2. In terms of your first question, so the challenge we have here is reporting on a quarter-to-quarter basis, and the numbers, you're correct, they do show percentage-wise a significant shift. But when you go into the actual appendix report, which is in page let me check which page it's on, page 11 onwards, you'll see the statistical process control graphs. And I think my team have tried to explain these before. In fact, they're very happy to come and do some training, which might be helpful to allow you to interpret these graphs. That was something that they offered when Brendan came and met with our team on a quality and safety round. But coming back to these graphs, what they're showing is actually the normal variation that occurs on a quarter-to-quarter or to a month-to-month basis against some of these measures. So as I say, apart from falls with harm, which has increased, and the notable increase in the quarter, only quarter 4, of serious adverse events relating to Maori, the others are all within normal variation. And so some quarters we have less and some quarters we have more. And we have only just received the national report from the Health Quality and Safety Commission, which allows us to compare our results with the national picture. And while I can't have that in front of you because it's only just been released to us, we have done some internal analysis on that, and it doesn't show that we are an outlier in any of our reporting rates. That's actually been discussed in some detail at our serious adverse events group this afternoon. So in the next time I report, I'll be able to give you a little bit more of an organisational view of our comparisons against the national picture. So I hope that reassures you. The other area that we will do as soon as we have sufficient historical data is the point that I mentioned at the beginning of the report. We're planning to move the dashboard to looking at rolling averages on an annualized basis as opposed to quarter reporting. And that will remove some of this, some of these spikes on a quarter basis, which I think present a level of data that isn't helpful to you as governors and gives you, you know, it's not a false sense of information. You're getting the accurate information, but you're not seeing the trend as easily as I would like you to. So as soon as we have sufficient data to enable that to be presented in this dashboard format, we will switch from a quarter report to a rolling average. And we think that will give you a better representation of what's actually happening in terms of percentage change.
Okay, Jenny. Brendan.
So thanks for that clarity, Judith. I have to say that when I got to the incidents graph profiles there with the red ink, I ran out of red ink, scrawling all over it, wondering what was going on. And then when I got to the graphs, I did note they were great graphs, but I probably struck because it looked like we were in, you know, we were within the realms of acceptability, but I hadn't aligned the two as well as I could have. So your explanation has helped, but I do support the question that Jenny asked. It made sense.
Absolutely, it's important you're able to understand and interpret what's quarter to quarter change versus actually what's a true trend, and that's why we include the graphs at the end.
Yeah, thank you, Judith. Look, it is always a consistent analytical problem when you're dealing with small numbers over a time period, and rolling averages will help you allow for dips and peaks. But what they don't necessarily do is help you understand peaks that may be associated with a challenge to the service. Sorry, Vaughan.
Thank you, John. Just come in at the end of that. Judith, thank you. You mentioned when Brendan had a quality and safety walk around. Just wanted to know what level will we recommence those, just as far as an ongoing work program alongside these type of reports?
Yeah, good question. We just talked about that yesterday, Vaughan. So the challenge we have at the moment is being able to run rounds in level 2 and enable sufficient social distancing, particularly in some of our departments where, as you know, our space and physical facility is quite cramped. So we're considering how we do that. We are planning to recommence the rounds now in level 2, but operate some of the rounds in person where the spacing and distancing can be managed. And other rounds, we're going to experiment with a virtual round, which will enable board members to participate through Zoom and have some dialogue with our clinical teams. Obviously, we don't know how long level 2 will continue for, and certainly once we are down at level 1, we will be able to resurrect the rounds in their entirety. So if you bear with us, I'm reviewing the timetable now and making sure that we can accommodate some of them through a virtual means. We're also taking account of some departments that, as you appreciate, have had to delay or postpone essential surgery, and they're now trying to address the backlog. And I think you'll appreciate we want to make sure that patients get seen as quickly as possible. So we just want to manage that effectively with the capacity of the clinical teams.
Appreciate that. Thank you. Thank you, Chair.
Thank you. Okay. Any further questions for Judith? Okay. Well, I'll note the content of the quality and safety dashboard and endorse the improvement activities planned for the next quarter. Do I have a mover, please? Thank you, Karen. Seconder, thank you, Heather. Those in favour, raise your hand. Those against? The motion is carried. Thank you very much. Thank you, Judith. Okay, on to the Māori Health Equity Dashboard Report. Te ara angitu. Sarah, Jeff, Scott and Debbie.
Thank you, John. We'll take the paper as read. This is the first follow-up paper following the development of the Te Ara Angitu reports commenced last year. This report focuses on child and health youth equity markers and was presented to Mana Whenua in August 2021. As you'll be aware, we previously reported issues with data quality. We've worked really, really hard on this during this period. However, it has been impacted by people leaving the organisation. The focus on these markers has created significant discussion and acknowledgement of the long-standing inequity, specifically in certain markers. 6 months is a very short time period to show sustained improvements, as we recognise systemic change is going to take a much longer period of time. However, in addition, there was a decline in many measures due to the COVID-19 lockdown previously, and actually it takes significant time to recover those. Teams are working collaboratively and creatively to try and improve the position as soon as possible. And I think it's essential to say that a focus and investment on an equity-based approach to the first 1,000 days is essential to ensure improved long-term outcomes from an equity perspective. And with our first 1,000 days sustainability funds, we will be focusing very strongly on that equity-based response around that as we move forward. Thank you. Happy to take any questions.
Sarah. Questions for Sarah? Look, it is indeed a very challenging area, and the life course approach that Sarah suggests in taking the first 1,000 days and investing that through the Sustainability Fund, I think is strategic and very sensible. But I think there are some deficits later on in childhood which need to be recognised, especially around oral health. But look, I have no question for you, Sarah, just grandstanding from the chair. If there are no further questions, I'll note the equity position for each of the indicators and update provided on next steps. Note the analysis, discussion and proposed next steps to improve Māori health equity and further strengthen MidCentral District Health Board's commitment to Te Reti o Waitangi, and endorse Te Ara Angitu report. Do I have a mover, please? Kia ora, Vaughan. Seconder, Oriana. Those in favour, raise your hand. Oh, sorry, Brendan, you had your hand up and you were waving. You're muted.
Yeah, so, sorry, it's a little bit slow kicking off there. Look, I just feel a bit guilty going, just receiving this report and charging us because there's just so much in it. And I'm just desperately running through. Can I just ask some questions?
Certainly.
God, now I've lost the page. Page 10, newborns. Can I just, newborn enrollment program has been in place since 2013 to address reducing numbers, which is 8 years ago.
Yeah. Yeah, and this is an ongoing issue that we address, and we're working really hard with our colleagues in newborn enrolment and our GP teams to make sure that there's adequate access to GP enrolment for newborns.
It's terrible, isn't it? I mean, it's just awful. So 8 years ago, we identified and we've still got this significant issue. So I wanted to highlight that. Then going to the next page, page 11. And I've used some pretty strong language here, which I won't repeat as I've written on my screen. Where is it? Hold on. This appears to be an issue for many whānau who may have access difficulty of their or the practices making. This manual process was instigated while waiting for a new, improved digital solution, but this is yet to happen. A recent quality improvement has led to some improvements, but the process remains predominantly manual. And then if we go to the next one, to insights, it's a whole story of, oh my God, what are we going to do sort of stuff, isn't it?
Yeah, and I think hopefully with the launch of the new NCIS, there's going to be an ability to be able to link that through, and we're working quite hard on that at the moment.
But it's
acknowledged.
That's 2022, sometime, God knows when. And that's another year, isn't it?
Yeah.
So I just bear with me just really, really quickly. If we go down to page 17, where we received a letter around our immunisation program, one of 17 DHBs to receive a letter. You mentioned that earlier on, didn't you?
Yes, we did, yeah. In the overarching dashboard, yeah.
Yeah. I think that, and then if we go to page 24, and we are talking about the patient journey. Can I just go through this one? So under discussion, our ability to follow the true journey through primary to secondary care proved extremely difficult. We only gained access to 2 primary practices to review their records. Despite initial indicated support for this audit, we were unable to get permission from PHO or GPTs to access their records. What? Really?
Jeff, do you want to respond to that from the ASH audit perspective?
Yes, I can respond to that, Chair. This exposed 2 areas. One is capacity, and the other was actually the inability to link up records. So we were dealing with ED records, hospital records, and trying to access PHO records. It was really difficult to get through confidentiality issues. It was really difficult to get through someone outside of a practice actually looking at data. And in the end, in order to achieve the audit and get some information out of it, we just had to proceed with what we had. The insights out of the audit, however, are about the difficulty of access of particularly some Māori families to primary care, needing to look at the whole journey and what else can we offer closer to home or closer to school or kohanga for some of these families. The other thing though is absolutely, as you say, Brendan, we need to join up these systems of clinical information, about where families get their care and not treat them as isolated silos. It is still an urgent need. All this ASH audit was a manual audit. It took hundreds of clinician hours to get this information. That in itself speaks volumes about what we can and can't do.
Yeah, look, so first of all, compliments for the work. I'm not criticising that at all. I mean, it's crucial, but I'm gutted with how painful the process is to get pretty fundamental information to try and make a difference into a section of our community that needs all the help that that we can offer. So I'm not criticising, but I'm, so if I then keep going, if I go through to page 27. This is around, now what is this around? Oral health. And remembering we invested in a new dental bus or something or other. And here we've got delays occurred when sites cannot host a service. Sorry, this is on the top of page 27. CAOH services, a guest at schools and preschools, and any service delivery is subject to their agreement and ability to host. Delays occur. Why would they not want to host this?
I'll jump in there. Thanks, Brendan. I think this highlights again a challenge around the complexity of working across communities. The dental service delivers to 108 different locations. So you can imagine each year as we try to service 30,000 tamariki, that's a large coordination effort. What Lee's referring to here, and he's certainly strengthened his processes, is that they've had a few surprises around schools that have gone on and done some refurbishment. They might have moved where we're going to park the dental van, etc., with no kind of prior notice. So they schedule for the year, engage at the start of the year, and then get impacted by the school not being able to host. Another really good example is we do have to be able to prioritise scheduling around school activities as well. They don't want the dental bus there during camp week when there's challenges with sports. Yeah, so it's a process and it's an engagement challenge, but it's certainly one that Lee's acknowledged and is picking up.
Okay, sorry to be grumpy.
Thank you, Brendan.
That I haven't finished.
No, that's okay. I'm just carry on. Jenny, to follow you.
Oh, okay. No, I think, hold on, you're right, I'm done. Thank you.
Good. Jenny.
Yeah, so thank you. And I am pleased that Brendan has maybe slowed things down and given this really important paper some, some discussion time. And I struggle to whether to bring it up or not, because I respect that there's certain things through, another hat that come in front of me. But I feel like Brendan has opened the door for me to discuss the newborn enrolment and immunisation, which those 6 weekends are so closely linked to that ability to be able to enrol that newborn. And, I think that it was acknowledged, in that in the narrative in terms of working with whānau as well as working with practices. But again, and I appreciate now that Kath's, opened the door so that when I come across cases like this, I can directly refer them in. And I have to say, immediately things are resolved. But what really concerns me is when that mother and baby doesn't happen to come in front of me, then how many more are there out there who still, to this week, not able to enrol their newborn locally? It is still happening. So if Brendan says this harks back to 2013, we're saying we're working with general practices. Why still are general practices literally turning people away and not enrolling those newborns? Because that then impacts our immunisation rates, and that impacts for a while, because catch up, or when we don't engage, early, that does have long-lasting implications. Who can we go to work this out so that this barrier stops happening for whānau? You can have all the coordinators, but if the if the whānau go directly and they're even getting turned away, where are we at?
Yeah, I think that's strongly acknowledged, Jenny, and actually it is really difficult for whānau that are turning up at practices, and if they are being turned away where GPs are not accepting new patients. And whilst we know that if we engage with a newborn enrolment coordinator, we then get them registered quite quickly, actually that's still not okay for whānau. So actually myself and Debbie and actually along with the PHO, we're working together to try and resolve that over the next 6 months, because it has been quite evident through this. We thought we were improving, and actually we've still got an issue.
Yeah, and I'll just jump in there as well. Thanks, Sarah. Agree. 2 key priorities around enrolment, and I probably don't need to stress the challenges we have around the number of GPs in the district and our challenges in some of our more rural areas. Is the 2 key priorities are newborns and Māori. So Think Aurora has been completely responsive each time we learn of these whānau, but we need to learn about the whānau. Thank you, Jenny. And that is difficult. People go off and have babies and don't engage with primary care at all. So it is a specific area that we will pay particular attention to, just like we are with immunisation.
Yeah.
Thank you, Deborah, and kia ora, Jenny and Brendan. 4 points that I'd written here were, how much newborns indicators amenable to the recruitment of more midwives? What role can whānau order navigators play in the transition from midwife to GP? What can we do about these barriers to GP enrolment? They're perennial and they just seem to be insoluble. And then, what are our next steps? Because, this is a chronic and almost irreducible problem. And if we're having to rely on the Sustainability Fund to invest in the first 1,000 days, the entry into that seems to be a systematic barrier for these children in whānau.
John, what I would like to say around the midwifery element there, we are well staffed with LMCs across our region. We have 78 currently registered as LMCs in this district, and actually, we're not aware of any woman not being able to access an LMC. So actually that element of it I'm less concerned about, definitely.
Yeah, it's that transition from midwife that Jenny pointed through to the GP that seems to be a challenge. Okay, well, I will apologise for not intentionally stymieing discussion on this, but anyway, are there any further questions for Sarah? Okay, well, I'll just put that we note the equity position for each of the indicators and update provided.
That one's already been moved by Vaughan and seconded by Oriana.
Oh, good. Well, are we ready to vote on this? I think so. Will those in favour raise your hand, please? Those against? Thank you. The motion is carried. Thank you. Thank you, Deborah and Sarah. And Jenny for your articulate critique. On to the Regional Services Plan. Kelly.
Kia ora. Just a couple of quick things. Obviously, this is Q4 for the Regional Service Plan, and going forward, there is no requirement to have a Regional Service Plan presented to the Ministry of Health for this current financial year. However, obviously, we are still working regionally, and there's a lot of work going on, which we will continue to do. And so, therefore, we will report against and keep you updated in regards to that work.
Thank you, Kelly. Are there questions for Kelly?
No questions. No.
Great.
Okay, look, my iPad is telling me I'm running low on power. I should make it to the end, but just in case I disappear, I'll attempt to rejoin on my phone. Okay, well, please note that there is no requirement for the Regional Services Plan presented to the Minister for the year 21-22 year. And note progress made on implementing Central Region's national and regional priority programs for Q4 of 2021. Do I have a mover, please? Thank you, Muriel. Seconded by Vaughan. Those in favour, raise your hand. Those against? Thank you. The motion is carried. Okay, and now for Judith and Kelly regarding the COVID Delta resurgence. That's item 6.5.
Chair. Thank you, John. We probably won't say much about this paper. A lot of the previous conversations have highlighted, I think, the response in the section associated with the Directorate reports. But I just wanted to highlight a few things in this paper. And Kelly, you might want to add anything you feel is necessary. I think the DHB excelled themselves in acting swiftly and I think very effectively in addressing this resurgence. I think the paper outlines the significant efforts everybody across the district, including our partner agencies, our local iwi, and many, many other people, including our communities, played in keeping our communities safe. There was a lot of work associated with redeploying staff, which probably doesn't come across in a paper like this. And I just want to acknowledge our staff who have been incredibly flexible just once again over this period in responding to their colleagues and responding to the community. And we're now in a stage where we're looking at lessons learned workshop to make sure that we get ourselves even better prepared should we see a further resurgence in the Delta variant. We hope obviously it won't happen in our community, but we need to be prepared should it happen. So we are now in that stage, and we will get ourselves in a position of being hopefully even further advanced. So there wasn't really much more I wanted to say, unless there was anything, Kelly, you wanted to say? You were involved directly.
Yeah, no, just reinforce what you said, Judith, really around this time round was, and there was more robust plans in place. It was smooth, the collaboration was fantastic. And overall, I just think it was a great process in the sense of being part of and worked really effectively.
Thank you, Kelly. And we have questions from Jenny and a comment from Catherine. Jenny and Karen.
Kia ora. So thank you for the report, and what a great way to update the board on the monumental amount of work that's being done, that has been done and continues to be done now with the review again of lessons learned. So thank you to everyone for that. My question is just in regards to page 3, I think it was, page 4. You have the statement towards the end there. There are some ongoing facilities challenges in some areas of the hospital. So I just thought, as a governor, it would be good to understand what those challenges were. Was that just a summary, and then later in the report it was things like the air filtration, those types of things? Or yeah, thank you.
Yes, essentially, I don't know if probably Lynn or Sarah might be best placed to answer that question, or possibly even Kelvin, if you want any more detail, but that is what we're referring to, yep.
So that work's just ongoing, Jenny. It's particularly around airflow and air filtration, and just starting the Delta variant, of course, is a bit different to what we were looking at last year. So we just continue to review our facilities, review our air changes, our airflow, and what we need to do to keep patients and staff safe in the facility if we were to have COVID or the Delta variant here.
And Lynn, sorry, through you, Chair, is to clarify, is that what limited, one of the considerations in that is the amount of people on certain wards that, yeah? Okay.
It's very much around reducing the flow of people around the organisation. Yeah. You want to keep as little flow as possible and keep people in their bubbles and not moving across the whole hospital or the whole organisation, Jenny. Yeah, very much so.
Thank you.
Karen?
Oh, thank you. Just looking at the diagram in Appendix 1 on page 11, which is really useful to be able to see that with the Team A and Team B. Now there's some red lines. I'm not sure if they're crossing people's names out or if that's meant to be trying to underline, but I couldn't quite understand what that was. Am I missing something, or?
Yeah, Karen, I think that's just the spelling corrector highlighting grammatical and spelling changes.
Oh, okay. It just made it hard to read those words. I was trying to figure out what the relevance. And the other question relates to, in terms of the ongoing operational processes across the hospital, or the DHB in terms of business as usual, what would the normal communication or lines of accountability be, or how would staff be aware of any changes of that that may occur during a time like this?
Sorry, just ask that question again, Cadden.
Sorry, I might not have asked it very clearly. So in terms of business as usual, and for staff within the organisation, how would they have an awareness of or be communicated any changes in lines of accountability? Are there any other changes in terms of the operational work of that as a result of the incident management team structure? So we can see this structure here. I guess what I'm asking is, in terms of how everything else continues as business as usual, if there are changes, how are they communicated, or are there changes to that as a result? There's a lot of personnel, I suppose, that are put in this structure to manage the incident management process, and I'm just wondering how that changes the other operational accountability and communication.
I can jump in there. The reality is that the day-to-day accountabilities stayed the same during the process. So people were undertaking their day jobs as well, but where people needed to take time out, it's the delegation to other people within the team environment, and the team is made aware of who's taken that responsibility at that time. So it's sort of team by team and communicated through the executive line.
Okay, thank you.
Thank you, Catherine.
Shall I
yes,
take
certainly.
the opportunity? So I just wanted to add a couple of things while we were talking about this. So there's the things that I wanted to add is that the national response to the COVID resurgence is ongoing and is likely to be ongoing for some months. In fact, I was on a Zoom just before this Zoom as the chair of the Central Region Chief Executives Group with the ministry and the other chairs as we work through what it means to respond to the COVID resurgence. And of course, as we know in this instance, it's particularly impacting on Auckland. And so in the Auckland context, across the country, a couple of things have happened. One is the ministry has needed to stand up an IMT. They were within this room, they were very slow to do that, but they now have an IMT structure in place, and that's continuing to support the current COVID resurgence. There are 4 key areas where DHBs are being asked to support Auckland, and that's generally by way of staffing support either within Auckland or and I'll get to or not within Auckland. So there's the ICU staffing, and we've got staff on standby for that. There's staffing to support the managed isolation facilities, and we've had 8 staff from our district health board in Auckland. There's staffing to support the contact tracing efforts, which is done from here, and Deb talked about that earlier with our DHB leading the efforts around the supermarkets that were identified as of concern. And then the other one is a call out for support for the vaccination efforts. So it would be fair to say the national response has been rather reactive, and what we're trying to do is bring a more planned and strategic and tactical approach to that. At the same time, I think as a central region, we're not convinced that we've got the right resurgence planning at a regional level in place. So what if it wasn't Auckland and it was Wellington? And so I've convened a session tomorrow. We're having the first session. There's representatives from all DHBs, and Kiriana Brookings co-chairing that with me. So we've got certainly elements of work that are really good around that the CEOs, particularly with Lynn and the other team, have led, but there's still more to do in that space. And so I think an ideal scenario would look like coherent local, regional and national planning that is linked and connected, and you understand what the triggers are at all times. Earlier we talked about the issues around the visitor policy. The mind boggles really what was going on north of here, because CEOs and DHBs have all agreed with the ministry to a consistent visitor policy. And from this district health board, you know that we've applied that to the letter of the law. I've always been a bit of a rule follower, I must say, mostly, unless my strong moral compass tells me it's not the right rule to follow. You know, I think there's still a bit of, you know, water to go under the bridge, shall we say.
Kia ora, Catherine. I agree, a strategic approach is required, and it's been called for by all sorts of commentators, but it's good to see leadership within the district health boards. I think one issue that's going to arise is 500,000 children over the age of 5 that when we have a licensed vaccine for them will require that, and better sooner rather than later, but we're now bumping into the problems that Deborah talked about the activities later on in the year. Whether we do this by schools or invite parents to bring them in their cars, I think we have to put something into that now. But look, if there are no further questions regarding the COVID Delta resurgence plan, I'd just like to acknowledge the comments made by Catherine, but we note progress in the... Sorry, are there any further questions, please? I don't want to... Yes, Jenny.
Yes, sorry, Kath, just to pick up on what you were saying, and I appreciate your further, you know, insight that you've given us as well, recognising that, like you say, this isn't going to suddenly end, and that we're part of a national support too, which again, we need to continue to be mindful of that. You know, we can't kid ourselves to think that in our own stretched environment that this doesn't have further implications too. So, you know, I think we need to be aware and appreciative and kind around that. You know, your point around the visiting policy, I do have to say is a good one, because what I very much found is that, like you say, you've chosen to lead it out following the rules, but I have found in the community it's opened us up to a heck of a lot of criticism, which then becomes unfair criticism. Some people's time potentially even be wasted in advocating for change when really it was just simply sticking to policy. And I'm sure well, I would hope, and I'm sure that that's something that perhaps you do feedback through in your realm, that when others aren't doing it, it actually does make it really challenging. And that, given we all know that there's emotional links to the well-being of some of these implications on whānau, but like Jeff always points out, to on staff that are having to manage this as well, you know, all that is what exasperates that further negatively for us when we're trying to do the right thing here. So I think that's been quite unfortunate for us if I was to bring it local.
Yes, and you just need to look at what's happened at Kanti's Manukau, who has the most restrictive visitor policy, equivalent to what you should have in level 4, and they've still had patients and visitors who have appeared in their hospital with COVID-19. And that's what the policy is about. It's trying to restrict the spread of COVID-19 unnecessarily. And, you know, that's kind of something that we're really mindful of. In this organisation, in this community, we would struggle immensely.
Thank you, Catherine. Look, I've had to rejoin on my phone because my iPad's about to die, and it'll probably do it at a most inopportune time. Look, I can't see everyone now, so I'm just going to have to rely on people speaking up. But I'll take it there are no further questions for Judith and Kelly. Okay.
That's
well,
That's
okay.
correct.
Thank you, Brendan. Well, I note the progress of the COVID-19 Delta resurgent response from the 17th of August to the 7th of September. Do I have a mover, please?
Happy to move, Chair. Oh, Brendan's moving, I'll second. Vaughan seconding.
Okay, those in favour raise your hand.
Right.
Those against? Did anyone vote against it?
No.
Cool, the motion's carried, thank you. Now on to our information papers, the locality progress report for Horowhenua. Angela.
Kia ora koutou. Given this is an information paper, I'll take it as read. There's just a couple of points I would like to highlight, I guess primarily things that have happened since the paper was written. I guess firstly just to say, in relation to the current plan, obviously progress has been really good with just 2 of the 70 actions listed now as being behind or challenges, and yeah, and 13 actions have been added to the original plan since it started. So that's all good to see. So section 5.2, the points of note. The second point there, I talked about the first 2 families of Colombian refugees were due to arrive in Levin in November. The October intake at Mangere has been paused, so I suspect that they won't be arriving in November. So I guess we'll wait for further advice as to when they will be coming. The other points that I'd like to highlight in section 6, the vaccination rollout. This paper talks about liaison currently taking place with key community members in Shannon. That all happened. Shannon, Tiwai Order and some partners within the community have run clinics in Shannon over the last few weeks, and the Shannon community are really happy with the services that have been provided as far as vaccinations go within their community. I've been in contact with Robert Ketu, who's their local councillor, and one of the local kaumātua there. He's really pleased, and yeah, some of the other sort of key community stakeholders got involved. It was really good. The issue we're currently trying to work through at the moment with the team is it currently looks like there's nothing available on Book My Vaccine for Foxton or Shannon, but we're just working out, people can get vaccinated through Tiwai Order. We're just working out how to make that appear on Book My Vaccine, because they need to contact directly. But the exciting thing, I guess, in Horowhenua, and particularly after the feedback we got in last year's annual public forum there, is the progress that is being made as far as work is happening on a clinical services plan, with Sapere doing that work at the moment, looking at how we can provide specialist services within the Horowhenua community to the current, but then particularly to the future population, which, as we all know, is growing extensively. And then the second, I guess, exciting development there being the one talked about in 7.2, where alongside Think Co-Order and HCL are looking at doing a new health and wellbeing hub facility in Levin. So yeah, 2 exciting pieces of work that I think the community will be really pleased to see happening. Has anyone got any questions?
John, can you see anybody?
I can only see 4 at a time, but I'm just paging through, and I can't see frantic.
I've just got a comment. It's Oriana here, John. I just want to congratulate you, Ange, on the report, and particularly around the Vaka Ora Pacifica initiative. It's fantastic.
Yeah,
Kia ora.
yeah, no, that is amazing.
Well,
John, I have a question, if you don't mind.
Go for it.
So just on the, and I know I can picture Chiquita's probably going to roll her eyes to the back of her head when she knows I'm going to ask about this. But anyway, it's all in a constructive vein. For the under 7.2, the health wellbeing locality plan. It's in the last line. It's envisaged that the development will be completed by 30 June 2023. Who sets up the timeline from there back, so that we've got a chronological target to meet that date? Who's the lead on that?
Kia ora, Brendan. I didn't roll my eyes to the back of my head, just so you know. As indicated in the paper, the Horowhenua Company Limited is taking the lead role in that, but it will be the governance group just being established that will determine that timeline in partnership with them.
Rightio. Okay. Thank you.
Thank you. Well, if there are no further questions and Coco's not asking a question, please note the update on the health and disability advice. Please note progress has been made in relation to the Horowhenua Te Mahere Hauora, the health and wellbeing plan. Do we have a mover, please? Thank you, Heather. Seconder?
Yeah, I'm happy to second, John.
Oh, thank you, Karen. Those in favour, please raise your hand. Those against? I don't see any hands raised for against, so I'll say that the motion's carried.
Yep.
On to our committee work plan.
John, this is really just an information paper. If there are questions, happy to take them.
Yes. Are there any questions for Judith?
No, good.
Okay, well, thank you. Well, I'll note the update for the Health and Disability Advisory Committee's work programme. Do I have a mover, please? Thank you, Brendan. A seconder? You'll have to say. Vaughan.
Yep.
Okay, thank you. Those in favour, raise your hand. Those against? Okay, I assume nobody put the hand up against us, so I'll take the motion as carried. Okay, there are no late items, so I'll just say that the next meeting of HDAC is on the 23rd of November in the boardroom. All things going well. Now I'll move on to the exclusion of the public. I recommend that the public be excluded from this meeting in accordance with the Official Information Act 1992, Section 9, for the following items for the reasons stated. Do I have a mover, please?
So moved.
Thank you,
Happy
Brendan.
to second, John.
Thank you, Vaughan. Those in favour say aye.
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 I'm sorry, I've just got everyone scrambling for their mute buttons now. Are those against? Thank you. The motion's carried. I declare that part one of the meeting finished at 11:55 a.m.